And tips and tricks, from the experts. And so, I'm not sure of the order of this, but we'll go through these. This is the opportunity to hear just 2 tips that are recommended by our faculty. So first we'll start with Dr. Lagast. You're going to talk with your first 2 tips for our audience.
Well, we got it already about the balancing of our knee. I think the major issue and what we find out also when we looked into the kinematics of the medial pivot, we find out the normal knee. And I think try to copy the normal knee with the kinematics. Is that really what we want to achieve with our medial pivot? But when we go then into balancing and whatever, I think it's more going into the individual knee. So we have to look into the balance of the knee, the laxity of that individual knee. So my message is, next slide maybe, that if you try to copy the individual knee and also then in your balancer, we all know you go for your stability on the medial side, but then the 2 dogmas, and we still will repeat it regarding the kinematics, so you will never accept that it's tighter on the lateral side than on the medial side, and then it's looser in extension and in flexion. And whenever you are in doubt also in balancing, what the message I always like to give is, when you're in doubt, it's better to have it a little bit too loose on the lateral side than too tight. Even if you did some release and you made it for your impression a little bit too loose, you will never have problem as long as it's stable on the medial side. But whenever you keep your medial side a little bit looser than your lateral side, you will have an unhappy patient. There's a lot of publications that show that satisfaction is also related to that imbalance on the medial side. So these are the message that I would like to bring you. And if there's a problem with your flexion extension balancing, that your flexion is over tight, then you have to adapt your flexion gap, and you have the opportunities there or to increase your slope or to downsize, because with that evolution you have that 4-in-1 cutting block, which allows you to have a nice posterior and anterior referencing, and there you can really play and adjust your flexion extension gap or with the slope. And we were discussing already, I like to look into the anatomical slope. I really like to copy that anatomical slope. So when you measured already, then you know if your slope was already okay, then you're not going to overcorrect too much in slope. We should downsize, but otherwise you can also increase your flexion gap by having that extra slope. So this is the message I would like to bring you.
Dr. Lagast, how much laxity will you allow on that medial side, and how do you know when it's too tight on the medial side?
Yeah, well, I explained yesterday, I think what I like in extension, when I do the valgus, is I would like it opening about 2 to 3 millimeters. As far as on the lateral side, it's not tighter. Okay, and I like to use my thumb test, because you can also over tight on the medial side. If you have it over tight, you will really have a over tight MCL, and it feels like a string, and you can't push it in, and that's quite painful for your patient. So don't be over tight as well. And also in flexion, I like to do my anterior drawer sign, where I will accept about 2 to 3 millimeters in the elderly. The younger and active sports, I would like to have them a little bit tighter, and I will accept about 1 to 2 millimeters. And again, you can easily check with your thumb test if your MCL is not over tight.
In lateral side, how much is too much, would you say?
Never. So as long I will accept, even I can tell you in the past when we had really extreme valgus, I did in the past lateral releases where I had to release everything, even the osteotomy of our lateral condyle that was advised to do if you need. And I didn't have any problems, although sometimes I had opening on the lateral side of more than 1 centimeter. As far as you get it nice and stable on the medial side. So for me, even in extreme varices where you have quite some extra laxity on the lateral side, I don't bother. And also, if I over-released a little bit on the lateral side, I don't mind neither.
So the medial stability is enough.
Yes, absolutely.
Okay. That's great. I think we're going to go to Dr. Macheras.
The trick with the PCL is, I presented yesterday as well my experience when we moved to this medial pivot knee ages ago. We were coming from the traditional surgical technique where you should have some stability. So when I was reducing the knee, and I have seen that I didn't have any problems with the PCL, I was maintaining. But following the patients, I realized that those patients, they were losing a little bit of flexion. So today it is clear that you should sacrifice the PCL because medial pivot is PCL knee, so it's a PS knee. So just sacrifice the PCL. Do not really bother about PCL because all of us, we know that the PCL, the majority of the cases, is diseased, and it's anterior cruciate and posterior cruciate shouldn't be left there because they don't do the job properly. And even in the experimental studies, they cannot balance the function of the PCL up to 1 or 2 millimeters. That means there is no reason to keep it. So today we do have the experience. We know that we should sacrifice the PCL when we use the medial pivot, the medial congruent knees. That is one of my messages regarding the PCL. And if we move to the next
Anyone else
slide.
on the panel the same? Resect in all cases? Anyone ever preserve it in any case? Valgus knee or any other reason?
No. No.
All right, so good tip from the panel. Resect it in all cases with this
Because
design.
you see, I maintained in 53% of, if you go to the previous slides, 53% of our knee. And then I realized that I lost some of the flexion. So I had to move forward and release. Today I release in all my knees.
Great.
And adding to what it has been said already about the tightness of the medial collateral ligament and the loosening of the lateral collateral, sometimes you need to do something more. So when you start, traditionally we know that we should release some of the lateral collateral or the medial collateral ligaments. Today we don't release any of the ligaments, we just remove the meniscus, and we try to externally rotate the knee, dislocate the knee, and then start cutting. So do not release the medial collateral ligament, do not touch it. And if for some reason you have a damage of the medial collateral ligament or it is loose, then you need to go to the next size up. Maybe you release the lateral collateral ligament, but in the end of the day, you shouldn't be dogmatic if you have any kind of instability. It could happen. We are surgeons, sometimes accidentally we damage the medial collateral ligament, doesn't work the concept, then you need to go for a constrained type of knee. But be careful, don't release any of the medial structures. You don't need to do with the medial collateral, with the medial pivot knee. And of course, again, with experience, we come to those dogmas. As Dr. Lagast said today, we got the experience, we got the knowledge, and we know what to do.
Right. It's interesting, these first 3 tips are all about soft tissues and appropriate balance, and yet we know how important that is. This knee obviously has great outcomes with many variable techniques of how to do it. But on the other hand, we now have robotic technology available. You know, Joe, you have some experience with robots. Do you think using that technology may help avoid some of these issues with soft tissue balancing? We're going to be able to put bone resections where we want it, where some of these things we're talking about may be less of a factor?
For sure. Using technology today, you can improve some of the things, but the knowledge and the experience should be taken into consideration. We know we have been through this surgical technique for many years, and today we know, and of course using technology for the younger generation, you can improve your results. But you know, technology, it is expensive, it's not available to everyone, and maybe, I don't know the audience, how many of them they have the possibility to use the technology today. And if you see, from my point of view, technology, it's not there yet, because it is changing pretty often. That means we don't have reached the point where you say this is the dogma, as Dr. Lagast said about medial pivot. Tight medial side, loose the lateral side, and don't bother about some kind of flex of instability in the flexion, but you have to have stability in the extension. So technology is there to be used, but still a few steps to go. Yeah.
No doubt what we do 5 years from now will probably look very different than what we're doing today. Dr. Karachalios, we're going to go with your tip.
Everything is all about the patella-friendly concept. And as I presented yesterday, EMP and AMP were patella-friendly designs. But they have got another extra manufacturing or technical feature that means the constant radius of the condyles. It's not only the groove, it is also the effect of the design. And one of the possible explanations is that you don't get sagittal plane instability, perhaps you don't get mid-flexion instability, which was well addressed by previous speakers. And of course, the quadricep efficient gait is quite important. Now, yesterday we have reported 4.1 or 4.6% anterior knee pain when we leave the patella unsurfaced. And please, next, it is, as you know, the comparison with historical controls at the level of 8 and 10. However, I have put another number, the 3.6, and there is a tendency in our series to be at the level of 3%. Perhaps we don't have the data now. Consider this as anecdotal evidence. We do a trick. We place the femoral component first and paying attention to restore the native external rotation. That means the orientation on the transverse plane. And in such a way, you restore the central of the ball in the area of the medial femoral condyle. Then we insert the trial tray plus the trial liner without the pins, that is free. In the most of the cases, not always I have to admit, if you perform a forceful flexion extension of the knee, the tibial tray goes where it wants to stay. This is a tip. I think that the reason for this is that the EMP has the 12 point a little bit posteriorly. We discussed about this, 2 millimeters, I think it is, posteriorly. And then the tibial tray, in the most of the cases, goes to the middle of the tibial tubercle. This is against the traditional teaching we got that we have to orientate it to the inner 1/3 of the tibial tubercle. And I think that there is a tendency for lower anterior knee pain. Of course, this has to be proved. And perhaps this TTTG type of relation and the distance that it was presented earlier today, perhaps there is an effect on this. But this is a trick that we do. And in the past, with our AMPs, we were placing, without this trick, intraoperative trick, the tibial tray to the inner 1/3 of the tibial tubercle. Now, the next one, resurfacing for me, the previous one, please. Resurfacing or not of the patella is your choice. But the Europeans most of the Europeans are convinced that resurfacing is not necessary.
Just going down the line, Percentage that you resurface your patella?
Probably 80 to 90.
80, 90.
Essentially 100%.
I come from 100% now to about 50-50. Because I was doing just for a bit of legal and insurance reasons routinely, but I found out it's absolutely, and especially I think in younger patients, because we are dealing with younger active patients, I think it's important if you can leave then. It's a very native patella, which very often has nothing, and we resurface. I think it's a little bit of a shame.
Resurfacing? What percentage?
95, 98% unresurfaced.
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 George?
Percentage of patella
Resurfacing.
resurfaced.
I never resurface. I have done it in the past. I have done a trial, and 500 knees resurfaced, 500 knees non-resurfaced, no difference. So today, with the modern implants, I do not resurface.
Joe?
I do almost all.
Oh, yeah. Philippe?
It's part of my routine to resurface them all, but I might change
Yeah, but you know, I mentioned yesterday as well, I don't really see any scientific reason. Every one of you, the guys who replace the patella, don't give, you see, an explanation why you resurface. Just because it's not a total knee, or because you are afraid of the lawyers, or because it's a tradition. I don't know. I mean,
my main argument is that the outcomes are pretty similar with the new implants, not with the old ones and the old prospective randomized trials. And then the failure modes are different. This is very important. Now, if you reduce the anterior knee pain in acceptable levels, I don't think that why you have to introduce a third component plus the possible failures of the interface, the fractures, malpositioning, and all sorts of things. This is my main argument.
and also the revision of the failed patellofemoral joint when you replace the patella, it's not that great.
Right. It's not benign.
Now-
This is your second tip?
Yes, this is. Now, my argument that I presented in Europe quite often is this. In order to achieve long-term survivals, good survivals, pain relief, functional recovery, you have to address all these cycles. It is the patient selection, it is the kinematics, implants with contemporary kinematics, the laxities, the alignment, the osteotomy, the type of osteotomy, the views that you have got, and also you have to address pain abnormal pathways in the knee, perhaps related to proprioception. The abnormal pathways in the knee are more often, you see them more often than the hip. Now, for me, in the past, I was not able to explain why surgeons they were focusing on the accuracy of the osteotomies, or they didn't pay, or they were focusing on the selection of the implant, ignoring the rest. In our days, if we want to produce individual surgery, and we have to prove that this theory, this approach is valid with long-term studies, you have to address all of them. And if you go for more patient-friendly alignments and laxities, then the next, I think that this implant, the EMP design, is the perfect choice for all sorts of individualized alignments. I personally perform restricted kinematic alignment with this implant, and I think in the future we will produce data to show if this theory is valid. But you have to address everything. And this was my first argument with the robotics and the navigation systems. They were producing papers with the improved accuracy, and this is proved, it's proved, at the level of 1 millimeter or 1 degree of the osteotomies, but then early functional results, nothing else at the level of 10 years, no effect to the survival rates. Behind this, in my opinion, is that you don't address all these cycles.
Philippe, in your experience, do you think that the medial pivot design may be something even better for kinematic type surgery?
I think it's the ideal implant for kinematic alignment. Yeah.
Great to hear. Oh, so going to be my tips here. So these are more technical. So if you're doing something like mechanical alignment or you're using the standard instrumentation, I think it's always okay to change the order of how you do your surgery. So I do resurface my patella, so I will do that first just to make it smaller, and I sublux it out of the way. Then I'll do my distal femoral resection. I used to prepare the femur all at once, but then I found that if I did my tibial resection next, it made the femoral sizer much easier to place. I was much more confident in that sitting flush against the distal femur and sizing. I see some colleagues who struggle to get the sizer on when the tibia is still in place, and I have a fear that they're either flexing or extending their femur, or they're just sizing it incorrectly. So I think just remember you can change the flow and routine of your surgery to make sure the instruments work in your hand. And then my second technical tip is that when I first started using this, I really learned quickly to appreciate the conformity of that medial side. And so usually putting the trial implants, the tibia and then the femur, and then I would always put in the tibial insert last. And with other systems, it's easy to do in mid-flexion, probably because we've heard about the mid-flexion stability of a lot of the other systems. This one I cannot get into mid-flexion, and I can't get an extension, so it's really only flexion because it's a little bit looser, as you've also described. So it's easier to put in 90 degrees of flexion in my hands, but sometimes I can't even get that in. And so in that case, sometimes what I'll do, it's probably less than 5% of cases, but I'll put the tibial insert on the trial first, and then I'll put the femur on top of that. And you would think that that would mean that the entire knee is too tight, the ligaments would be too tight, but what's amazing is that that medial side is so conforming that once you get it over that lip and you get the knee reduced, the knee actually goes full extension, has perfect stability. But this is just a little tip if you're struggling to get your insert in during your trials. All right, David, let's go to your tip.
All right. Well, these tips are geared maybe more towards surgeons who are considering kinematic alignment or who are early on in their experience. I think that as most surgeons or many surgeons do with total hips, I think pre-planning with total knees is important. Kind of gives you an idea what your targets are. Whether you use the microport mechanical instrumentation that's been developed, or if you use some augmented reality technology, I've kind of gone that direction. And also, you have to ask yourself, are you going to do restricted or unrestricted kinematics? It's kind of a maybe philosophical question. If they're with outside of certain boundaries, maybe that's pathologic and led to their current state and the disease. So I think for me, it makes sense to do restricted. It's obviously a static two-dimensional imaging, but I think it does give us a good landmark and good roadmap. So in this case, this is a pretty challenging case, fixed valgus with a significant, 15 or 20 degree flexion contracture. We actually ended up doing his left side, which is more symptomatic first. But so I think the right illustrates, the importance of planning, getting the lateral distal femoral valgus angle, the intra-articular angle there. It's maybe hard to see with these numbers, but I think that's probably the majority of your correction in your hip, knee, ankle angle at the end of in post-operatively, and then you also measure your proximal tibial varus angle. Next slide. So, you can come up with some calculations, just kind of, I'm sure there's something that's a little bit more robust and useful, in the literature or amongst surgeons. But you just kind of take the differences that you anticipate. You can measure it post-operatively, compare it to what you've done intraoperatively. And I think that, with advanced technologies, you can get, again, within 1 millimeter, 1 degree of accuracy. You can see that our plan was maybe leaving him in a little residual valgus, which I think maybe men don't mind as much. And we ended up within a degree of our planned correction. So. Two, with kinematic alignment, you're using the soft tissues to guide you, a soft tissue procedure. So you definitely have to clean up all the osteophytes, kind of like a unicompartmental knee. You just want to clean everything up and then really let the soft tissue guide your surgery. So pretty quick tip. And again, this one, if you do the femur first, occasionally with bad varus knees, you have a scenario where the tibia is subluxed. And oftentimes there'll be impingement on the tibial spines. So once you get your femoral component on, you can either use the snap-on spacers, or you can actually just cut your tibial spines. Even if you remove your tibial spines to kind of prevent that impingement in the mesial kind of aspect of the knee, that'll allow you to get a better read of your ligaments and I think really take you to the next step. Once you do make that next step, it can be pretty unnerving. You know, if we're used to taking a 1 or 2 millimeter cut on the medial tibial side, this is, you have to reestablish your expectations, what you're going to see. Your osteotomy is a little bit more even. So if you're taking 6 millimeters on the medial side, it looks pretty substantial. So, you know, but that's how it goes. So.
Perfect. Okay, so I think in conclusion, I think what you've heard today from the tips from the experts are, you know, you want to make sure that first, so for do not, make sure don't keep your PCL, don't accept imbalance, don't release your superficial MCL, let those soft tissues remain alone, don't overhang, don't keep residual valgus, don't chase equality in medial and lateral flexion gaps. Lateral side is able to have some more laxity, and you don't need to routinely resurface the patella apparently. And in terms of do, you know, keep your patella philosophies preferences, keep your alignment preferences. Always use posterior femoral condyle cut checker, that money clip if you're not familiar with it, and translate the block. Get more incremental sizing and bone resections based on that. And always check the tightness of your IT band and releases when tight in varus knees, especially to decrease lateral pain. So that's a great tips from the experts.